Hello, Dr. Crose here with Capitis Medical and Aesthetics. One of the nice things about working both in acute care medicine inside the hospital and having my own private practice is I have my feet in both sides of the industry. And it's interesting because I want to bring up an issue that I think we don't address enough as physicians. We are very beholden to the industry and the payers in terms of the regulations and the policies that they make. And sometimes the hardest thing is practicing what is good medicine and also what is morally the right thing to do in certain situations. We face these conflicts a lot in medicine. I was reading an article in ACP Internist actually, and it was talking about the proper way to treat urinary tract infections. Most of the physicians know that we shouldn't be prescribing antibiotics for asymptomatic bacteriuria. We know this, but a lot of times in the hospital we treat it anyway. And I wanted to bring this up because I personally know that most of the time these infections or even the bacteriuria will pass on its own, as 5% of all patients actually have bacteria in their urine. Especially as we get older, that percentage may even go up higher. Let's just hypothetically put this out there. An elderly person comes in, they're confused, they have worsening dementia or delirium on a demented state, and the family can't take care of the patient. They have been progressively getting worse. The patient's not terribly sick, but just clearly is not in the right mind. Now this family is at wit's end. They don't know what to do with the patient and they really need some help. Well, one of the problems in the American medical payer system is that Medicare sets these regulations where you have to be an inpatient for 3 days in order to qualify for a skilled nursing facility stay. So as an acute care physician, I have to think about this. Do I wait to get the culture back and start the treatment? Do I treat right away even though they're hemodynamically stable? How do I find a way to so to speak, buy a 3-day stay in the hospital as an inpatient and not under observation? So many times I feel morally obligated to look for a reason to qualify that patient so that the family can get some reprieve from everything going on. So I will start treating with antibiotics and classify it as acute encephalopathy due to sepsis from a urinary tract infection. And I'll do this so that I can qualify that patient for a 3-day in-house hospital stay so that they can get into a skilled nursing facility because the family just really can't do it anymore. This is one of the things that we do in medicine, and even though it's probably wrong to treat these patients with antibiotics as they're not necessarily that sick, we do so anyway. I know I'm a culprit of this, and I'm sure many of my colleagues do this as well. So I just wanted to point this out as just one example of many of the things that we face as physicians in this industry. Is the system broken? Pretty close. Is it perfect? By all means not. So I think that these are things we need to start addressing as a culture and a society. Our society needs to realize that we have to come up with a plan for our elderly as they get older. Most cultures take care of their elderly in their own homes. Our culture is a very nuclear family-based type of setting, and we just don't have that same expectation of ourselves to keep our loved ones in home as they age. Maybe we need to readdress this and think about this, or we're going to have to completely create and alter our care system for the elderly as they get older. Thank you very much. This is just another insert on my part into some of the issues that we're facing in the medical industry. Take care.